My name is Alan Shindel. I'm an associate professor at the University of California, San Francisco, and I had the privilege of being part of the AUA Guidelines panel on erectile dysfunction. So what I hope to do over the next 15 to 20 minutes is go over some of the nuances, some of the processes we went through when we developed these guidelines, articulate how they might be relevant to your practice, but again, recognizing that these are guidelines, not laws, and therefore the best situation for an individual patient is going to be something that you will have to determine interacting with them, knowing their history and their goals. In terms of disclosures, I have no commercial COI for the past 16 months. I do have a number of leadership positions with the International Society for Sexual Medicine and the Sexual Medicine Society of North America, but no commercial COI over this period of time. So the guidelines, as I articulated, are meant to be a framework, a process, a distillation of the evidence basis that exists. And again, it's not meant to be a law or saying that this is the only proper way to handle a patient. But it is something that we're quite proud of because it integrates the best available evidence from peer-reviewed literature with the assistance of a methodologist who really helped us do it the right way. It involves a number of expert opinions, again, informed by the literature, informed by clinical practice, and multidisciplinary in nature, where we're getting perspectives from urologists, obviously, but also mental health specialists, patients themselves, primary care providers. And really, ultimately, despite all that evidence, despite all that work, we acknowledge that the fact is that when you are with a patient, ultimately, that conversation, that relationship is what has to dictate next steps. I want to acknowledge the other members of the panel, one of whom at least is in the room with us right now as part of our critique panel. So, starting off from the beginning, erectile dysfunction, defined in 1991 as the recurrent or persistent inability to attain and or maintain an erection sufficient for satisfactory sexual intercourse. There are multiple components to that definition, and you can read each individual word and see that there are situations where one thing might apply. A man might be able to attain an erection but not maintain it. He might have an erection, but it might be less satisfactory than what he's used to. Any one of those situations potentially could be defined as ED and therefore meriting treatment and evaluation. I speak to my patients about how this is both a mental and a physical condition, and I really try to drive home the point that really there is no sexual problem that has probably ever been had by any human anywhere that does not involve at least some component of psychology, either as the primary factor or a secondary. A lot of patients aren't necessarily willing to hear that. They want a physical cure. They don't think it's in their head at all. But I'll go over some techniques that I use to kind of convince them of that and at least make them acknowledge the importance of the mental health, the relationship aspects to sexual function. Epidemiology, again, these numbers are derived from a number of single-item questionnaire studies by Ed Lauman. Excellent work done actually at a global scale in a later follow-up study. But you'll see that it's a very prevalent problem, and the prevalence increases with age, as we all know. It is frequently comorbid with other urologic conditions, so you can be fairly well assured the patient coming to see you with BPH or who has psychological issues is certainly at increased risk of having erectile problems as well that might merit discussion, either because they're a problem in their own right or because some intervention that you're proposing, a prostate procedure, a prostate medication, other operations, etc., could have ramifications for their sexual life, and if they're already coming into this with a sexual problem, it might make it that much worse. I typically conceptualize the organic etiologies of ED into four large categories. And the top of the list, the vascular, is the one that I really like to emphasize most with patients. I tell them whatever's good for your heart is going to be good for your penis too. And while they may not care about the heart attack they'll have in 10 years or the stroke in 20 years, they are oftentimes very concerned about the ED they might have within 5 years. Therefore, I make it a point to tell them about these relationships, about how their high blood pressure or their high cholesterol is potentially contributing, and that leads into a discussion of how that might be something they can intervene upon, something that they have some degree of control over, and therefore something that they can do to help themselves. Neurologic disease is also very relevant. As you're aware, the burst of nitric oxide that stimulates erection function is oftentimes derived from the cavernous nerves. And for that reason, an intact nervous system axis is very important to erection function. Endocrine disease, primarily we're talking here about testosterone, and plenty of patients will come in to talk about it. This is a somewhat fraught conversation, and it's a very complex topic due to a lot of competing interests and data that are out there. But it is something patients will ask about, and there is reason to believe that there are situations in which testosterone deficiency plays into the issue of erectile dysfunction. Lastly, the psychological stressors, things that are actually potentially on the patient's mind. The conversation I have stems from the fact that ultimately the human body has only one sort of stress response: release of adrenaline, activation of the sympathetic nervous system. I tell patients this because when they're stressed about sexual function or stressed about their relationship with their partner because of it, their body's only going to know one way to react: activate the sympathetic nervous system. And I make clear to them that with activation of that part of their nervous system, they'll get contraction of arteries, release of adrenaline. All of this is going to be counterproductive in terms of getting and keeping an erection. So I put it in terms that the psychological things we talk about, the psychological aspects that lead to erectile dysfunction, have a very physical basis. And with that context in mind, a lot of patients are a little bit more willing to entertain the notion that psychology plays into this, and that might be something that's worth intervening upon. So, coming back to the guidelines, in terms of methodology, we searched back to 1965 and identified almost 1,000 papers that met our inclusion criteria. Those of you who are familiar with the guidelines are aware we have two basic axes of which we base our guidelines. The first is the evidence strength. This is based strictly on what do we have out there in terms of literature. So obviously double-blind, placebo-controlled, randomized trials are kind of the highest level of evidence. You have cohort studies, case series, et cetera, that are progressively less and less robust. This determines the evidence strength rating. This is separate from the recommendation, which is ultimately what the committee thought a practitioner should do in most cases in clinical practice. Obviously, you're more often going to have a strong recommendation in the context of level A evidence. However, that's not strictly always going to be the case. It's possible to have very robust evidence but a weaker recommendation, and vice versa as well, for the simple reason that there are considerations that the expert panel brings to the conversation and that can inform the degree of recommendation that's made. This also has a lot to do with the risk-benefit ratio in terms of what we think the patient is taking on in terms of risk compared to the benefit they might derive. So going over a few of the key guidelines, this one's self-evident. Obviously, you have to talk to your patients. You have to get their history. It's good to have context about the onset of their condition, how it's impacting their relationship with their partner, what they've done about it so far, any other comorbid issues. This is all pretty fundamental stuff. Select laboratory testing, again, that was left a little bit open-ended, but the things that I like to get would be a lipid panel, hemoglobin A1C, potentially testosterone, which we'll talk about later, and those are the basic kind of vascular type labs that I want to make sure patients have had. In routine practice, it's very beneficial to administer an instrument like the SHIM, or the International Index of Erectile Function. The erection hardness scale, another option, very simple 4-level scale, determined basically dictating how strong a man's erections are, how rigid they become. Very simple to use, very simple to apply. These are very useful not just for initial triage, but also for assessing response to treatment. Is the man better off than he was after you've initiated your first treatment? I'll lastly add that, as I've discussed, vascular disease is a very major component of ED and one of the factors that people have some degree of control over. So in analyzing for these risk factors, tobacco use being a very prominent one, but stress, poor dietary habits, sedentary lifestyle, these are all clearly associated with ED, and they are things upon which a man could take some intervention. So I had mentioned testosterone earlier. The guideline panel did suggest that morning total testosterone be assessed as part of a routine in the patient presenting with ED. The data on testosterone are somewhat controversial, and you're all aware that this is marketed very heavily to patients as sort of a cure for all that ails you. And there are certainly plenty of patients who do legitimately have testosterone deficiency that I believe do benefit, but not every single man. And the relationship is particularly complicated when you talk about erectile dysfunction. This meta-analysis from one of our colleagues in Europe indicated that there was data to support the notion that testosterone repletion can produce improvements in erectile function in carefully selected men who have both symptoms of hypogonadism and biochemically low levels. Now, the degree of improvement in general, thinking about testosterone monotherapy, looking at the overall body of data, was relatively modest. So it does not necessarily take a man with moderate to severe ED into the normal category. A man with mild ED, potentially. I'll say, it's not on the slide, but I'll say where there is more robust evidence is the notion of a man who has low libido. If libido is a primary component or a large component of his sexual concerns, there is much more robust evidence to suggest a benefit of testosterone supplementation for that man. And certainly that man with low libido, whose libido is subsequently boosted, is probably going to realize more substantial benefit in terms of erections, simply because his head is in the game. He's interested again. That's going to have a very important ramification for how well he does in the bedroom. I'll mention briefly the concept of free testosterone. There was not sufficient evidence to merit inclusion of free testosterone testing as a recommendation from these guidelines. It is something that remains controversial and of interest to many practitioners, and again, there's a lot of opinions on that. It is something that can be checked routinely, but it's again not officially part of the guidelines. I will say, and there are data to support this as well, that a man who is testosterone deficient and has failed PDE5 inhibitors can in some cases be salvaged by testosterone replacement therapy, and there are data to support that notion. So mental health guidelines. Again, I've probably emphasized too much how important I think the mental health aspect of sexual dysfunction is, but I do think that it helps patients to recognize, again, there is a mental health component, there is an interrelational component to this, and having a conversation with someone who's really expert, someone who has more time than we do as urologists to sit down and really delve deeply into the psychological ramifications of sexuality can be of great benefit. I've never seen it be harmful, at least. It can be cost prohibitive for some patients, but for those who are able to access these practitioners, I do highly recommend it. There are data to support the usefulness of psychological intervention in sexual dysfunction, specifically ED. This study here, looking at a group of only 100 men, unfortunately, because it was, 398 men from 2008, looked at a number of men who went on to group therapy and did notice a significant improvement in the prevalence of ED. The ED prevalence went down over time in the treatment group versus the waitlist group. So lifestyle modification, again, a big topic for me when I discuss this with patients. I really want patients to recognize that they have some agency in this. They can actually take control and make a difference for themselves. And one of my favorite studies, it's somewhat old now, but it was a randomized controlled study of an intensive lifestyle intervention out of Italy, looking at this relatively ambitious set of goals for these diabetic men. However, those who were able to attain it, the men who were actually able to realize some of these goals, had a decline in the prevalence of erectile dysfunction. We have here the lifestyle intervention group, where you can see that between baseline and the 2-year mark, there was a marked increase in the number of patients with no ED versus no real change in the control group. Per protocol, per protocol, that was the result, but actually if you look at the intention to, per protocol analysis here, the men in the control group who also attained these goals, one or more of these particular treatment goals, did also have a significant improvement in their erectile function. So ultimately, it's something patients can control, they can take a step towards this, and it can give them some sense of agency over their condition. Obviously, PDE5 inhibitors are the mainstay of clinical therapy for ED. They're the thing we give out the most. And when you prescribe it, something that's often lacking from what happens with the primary care provider, when you prescribe it, you need to give instructions. Again, the 3 fundamental things I tell patients 1 hour ahead of time, 1 to 2 hours, depending on what kind of pill you're giving. Without food, again, most important for sildenafil, vardenafil, and avanafil, not so much for tadalafil, but sexual stimulation. And I can't tell you how many patients I've seen coming in to see me like, well, I took Viagra once, nothing happened, then I gave up, and then I got referred to see you. This happens semi-frequently, and when you delve into it with patients, you'll find that oftentimes the failures you get from a primary care provider, they really haven't been instructed on how to do it right, and they haven't given it enough tries. So there are data to suggest that the man who fails PDE5 inhibitors can be salvaged with education. These are older data, but again, it underscores the point. And we still, to this day, have issues with patients coming in not having really been instructed on the right way to take these pills. The data on penile rehabilitation, I think most of us do it. Most people who do radical prostatectomies do advise some form of penile rehabilitation. I think there's nothing really wrong with it. I think it potentially has benefit based on case series and some animal data. However, a meta-analysis of the 3 randomized controlled trials of routine dose PDE5 inhibitors versus placebo did not demonstrate a consistent benefit in terms of recovery of spontaneous erection or response to ED therapy. It remains controversial, and I see plenty of patients who are on penile rehab. I'm supportive of that, and I tell them that this is certainly something that has not been shown to make things worse. It does keep your head in the game. There's some value to it. but the data to this point have not demonstrated a very robust relationship between penile rehabilitation and eventual outcomes. Other medical therapies for ED. Now, you'll notice that in this statement, there is not a stepwise progression here. This is not something that says you have to go to PDE5 inhibitors first and then progress to these other therapies. That was deliberate. And the notion is that there is no stepwise approach to management of ED. Ultimately, all options should be presented. The patient should be allowed to select from those options which of them is most in line with his values and goals for treatment. Penile prosthetic surgery certainly is an option that should be presented early so that they're aware of it, so that they can take some time to wrap their head around it and understand that it is an option that works. Many patients aren't aware that these devices even exist, so having that knowledge implanted early can be quite important for eventual uptake for those patients who are appropriate candidates. They are very successful. For the appropriately selected patient, they do quite well, and many patients are very satisfied afterwards, as are their partners. It is important that you counsel your patients ahead of time. Many patients expect a bionic penis, $6 million man type thing, and ultimately we all know that's not what's realistic. Counseling on what's realistic up front is going to lead to better outcomes down the road. And Landon Trost, one of my colleagues who is absolutely phenomenal, has a great mnemonic for this called the cursed patient, and I won't go into it for sake of time here. But he lays out a number of criteria that some patients bring to the table that make them a very poor candidate for implant, or at least a poor candidate up front. They need intensive counseling if you ever decide to do this sort of operation on this sort of patient. So very important for long-term outcome. In terms of other surgeries, revascularization surgery is a prominent topic. People are interested in it. There is a very select, very discrete group of men who may benefit from this. That is to say, young men with absence of vascular disease who come in with a history of trauma and therefore a disruption of the penile circulation that might be candidates. This is super specialized stuff. Again, you're very rarely going to meet this particular patient, but it is theoretically an option. Contrast that with what we think about venous surgery, that is to say crural ligation or venous ligation surgery to obstruct the venous outflow for erections. The data on this are very heterogeneous, generally very old and not that robust, and therefore at this time we do not recommend any kind of penile venous surgery for patients with ED. Other things that are out there, I think we're going to hear some talks on this, and I'm excited to hear about them later, about shockwave therapy, stem cell or gene therapy, platelet-rich plasma. I'd say for the first two bullet points on this list, there are some data. Not great data, not ready for prime time data, but some compelling data that there might be something here in the future. PRP, on the other hand, there are not, at this time, at least not to our knowledge at the time of review, any robust data to suggest efficacy. So therefore, this one was treated as experimental. I'm not sure the exact distinction in terms of semantics between investigational and experimental, but I do think that we're approaching PRP with much greater caution at this time, simply because of a lack of data. So just to wrap it up and to kind of illustrate some of the principles that the guidelines lay out here, I'll present to you this patient, probably familiar to many of you. You've seen a man like this or similar to this in your practices. Post-radical prostate, new sexual relationship, poor erectile function, but interested in doing something about it, and resistant to the notion of medications. Fairly standard history, again, prostate cancer treated apparently successfully in the recent not in the distant past. Past medical history, again, what you'll normally see, and no other surgical history. On physical exam, again, fairly standard issue patient here. He does have a palpable midline nodule, which would potentially inform the question of whether or not adjunctive things need to be done at surgery, something that can be elucidated with further evaluation. And then a low serum testosterone. Again, controversies about testosterone supplementation and prostate cancer exist. In this case, testosterone repletion could theoretically make a difference, but given his other conditions, probably not going to save him. So the steps that can be taken, obviously evaluate the problem, present options. In this case, there might be utility to obtaining a penile duplex ultrasound for the notion of really stratifying how likely is he to succeed from some sort of medical therapy, and then discuss penile implant. In this particular situation, the patient did have a penile Doppler. It did demonstrate very poor arterial inflow and some venous leak, as well as some penile curvature, so not the kind of man who's likely to benefit from medical therapy. He went on to get a penile implant, corrected his curvature. Things were cycling well, and at 6-week follow-up, he was doing quite well and planning to start sexual activity very soon. So ultimately, the guidelines are not laws, but they do provide some evidence to help inform practice. I think involving it with a partner and lifestyle modification makes a big difference. And mental health is very important as well. Thank you for your attention.